Next 2-3 minutes we will start. We will see if the first speaker who is supposed to join us, if she is able to join us, it is fine. Otherwise, I can start with module 1. We'll just wait for a couple of minutes more.
Dr. Prema has joined us, madam, for third module.
Dr. Prema has module 3. So shall I go ahead and start with module 1?
Okay, ma'am.
We'll just wait for 2 more minutes. Dr. Mudita, can you please check? There are some messages where they are saying that they are unable to join in. But this Zoom link was for more than 100 participants. So I'm
Okay, madam. I'll share once more.
Yeah, just check, please.
Ask them to check the mail, madam.
Yes, some have not registered.
Password is on the mail.
Okay. But many times you don't need password.
मैडम आज जरूरत पड़ रही है.
अच्छा ठीक है. So I'll just send it. It is Dr. Alta from Sagar. She is saying that she has not received the password. So another 1 minute to go and we'll start. बोलो।
आपकी आवाज नहीं सुनाई दे रही है उसमें, आपको बोला भी मैंने अनम्यूट करके।
तुमको ज्वाइन करना पड़ेगा, तुम्हारा कंप्यूटर।
मैंने ज्वाइन कर लिया, मुझे आपकी स्क्रीन में सब दिख रहा, आप देख भी रहे हो।
तुम अपने कंप्यूटर से ऑडियो ज्वाइन करो।
ओके।
लॉग आउट करके कंप्यूटर ऑडियो ऑन करना पड़ेगा तुमको।
अच्छा ठीक है ठीक
हाँ,
है, मैं फोन से ही कर रही हूँ, मैं करके देखती हूँ।
हाँ हाँ। Even Dr. Nalini Mishra is saying that she is not able to join in. They are saying registration is closed. Dr. Mudita, can you please check?
Okay, madam.
Maybe if we have a support group over here by the name of MITI Events Private Limited. So if we can put a chat for them, maybe if it will work. Is someone there from the support group?
Yes, ma'am. Event management people is there.
So if they can help us out with letting people in.
Actually, they need to fill the form. They are not filling the form.
No, Nalini madam is saying that she has filled up the form. Nalini madam is saying
I'll
that
talk
she,
with her.
you talk to her and find out. She's saying that she has filled the form and they are saying that now that the registration is closed. I'm not sure whether there was some time limit for the registration.
No, ma'am. Person मतलब Zoom की जितना वो रहेगा ना 100%, 200%, तो वो full हो गए होंगे.
डॉक्टर गोरे का भी आ रहा है. Sorry, registration is closed. Chalo, that's fine. Maybe we'll start and see if the MITI even can help us out. So Mudita, would you like to start with it or shall I go ahead and start with module 1?
मैम आप start करो, मैं घर पहुंच के करती हूँ, रास्ते में ही हूँ.
अच्छा ठीक है. So good afternoon everyone. This is a effort taken for Bhopal Society by the team to make them aware about respectful abortion care, which is a joint initiative of FOXI and WHO. We all are aware that there are certain changes which have taken place in medical termination of pregnancy by the amendment bill. So this is an initiative which FOXI has taken to let their members be aware about the changes which have been taken place in the bill. So I'm going to take you through. This session is meant for 2 hours and we have 4 modules with us. These modules are all which we have received from the FOXI head office. Me and Dr. Mudita have attended the trainers of training program for this. And there are other speakers also from different societies. The initiative is to have as many inputs as possible and to make the society members aware by the month of April to be aware about what are the newer medical termination amendments which have taken place. So I'm going to take you through the module 1, which is Medical Termination of Pregnancy Amendment 2021, Respectful Abortion Care, a joint initiative of FOXI and WHO. This is Master Trainers Orientation Virtual Program. After you go through this with your pre-test and post-test, you will also get a certificate where it will say that you have been trained for the newer MTP Act. So objective of module 1 is to disseminate evidence. We will take a closer look at what are the new laws, what are the changes in the rules. Unsafe abortions in India lead to mortality and morbidity and hamper women and girls' full participation. We all are aware that. So every day in and out, we come across at least one patient with whom we have to struggle with medical termination of pregnancy. 8% of maternal deaths per year are due to abortion. Third leading cause of MMR. Nearly 2 out of 3 of abortions performed are deemed unsafe. Nearly half of pregnancy-related deaths are in women and girls under year of 24 age of their life. So when is abortion considered safe as far as WHO is concerned? Their definition of safe abortion is if it is done by appropriate method and is done by a trained person. If both criteria are met, it is called as safe. If one criteria is met, it is called as less safe. And if both criteria are not met, it is called as unsafe. Medical Termination of Pregnancy Amendment 2021 is safe and comprehensive care which is mandated by law. Let me take you through the salient features or the changes which have taken place in MTP amendment. Modification in requirement of provider. As per the previous act, the requirement of opinion of 2 providers for MTP were there up till 12 weeks. Requirement of opinion of 2 providers for MTP from 12 to 20 weeks. As per 2021 amendment, requirement of opinion of 1 registered medical practitioner for termination of pregnancy is required up till 20 weeks of gestation, and requirement of opinion of 2 RMPs is required for 20 to 24 weeks of gestation. Potential outcome is to increase in number of facilities, especially in public sector like PHCs, which are eligible for service provision till 20 weeks. The modification for vulnerable group of women, as per previous act, it was permissible beyond 20 weeks only when it was immediately necessary to save the life of pregnant women. As per 2021 amendment, enhanced the upper limit of gestation from 20 to 24 weeks for special vulnerable categories of women, and further enhanced. Can you please keep yourself Can you please make yourself mute, please?
Done, madam.
So the amendment says further enhancement for birth defects not compatible with life on medical board consensus. The potential outcome is to increase access for vulnerable women to safe and legal abortion services, which is defined by the Rules Committee, includes violence victims, minor, among others. So MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of pregnant women. And as we are aware, it has enhanced the upper gestational limit from 20 to 24 weeks for special vulnerable categories of women, and further enhancement for birth defects not compatible with life on medical board consensus. Potential outcome is to increase access for vulnerable women to safe and legal abortion services, as per defined by Rules Committee, includes violence victims, minor, and among others. Oh, I'm not sure why my screen is stuck. The previous act had provision for termination of such pregnancies only up to 20 weeks. Now, as per 2021 amendment, the upper gestational limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by a medical board. Every now and then, after having a ultrasound report, sometimes we are caught in this kind of a dilemma, what to do now. So now the amendment of bill lets you to apply to the board, to the medical board, with all the documents whichever you have, and the patient can ask for termination, which the board can certify, and the patient can undergo termination if there are a lot of congenital malformations. The potential outcome is increase in access to safe and legal abortion for women who often seek services late beyond legal limit for termination of pregnancy, with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and forced cases. Modification related to marital status. The previous act, the condition of failure of contraceptive was applicable for only married women or her husband. Now, as per 2021 amendment, condition of failure of contraceptives is to be extended for any woman or her partner. So this has increased access to safe and legal abortion for any women, irrespective of marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. So if the patient is not married, we are having a change in the society, they are living together, living partners. So in that case, also the client, not the patient, the client can come forward and have medical termination of pregnancy as per the newer change in the law. Insertion of new clause for strengthening privacy. The previous act used to say the medical termination regulation 2003 mentioned that information should not be disclosed except under authority of law. The new insertion which has taken place in 2021 is name and other particulars of a woman whose pregnancy has to be terminated shall not be revealed except to a person authorized by any law for the time being in force. So the potential outcome by this change is it increase in privacy and confidentiality of abortion seekers, increase demand but need to safeguard rights and dignity of women, and provide respectful bias-free services including counseling and contraception. So the law's salient features which prioritize confidentiality and safety, where the name and other particulars of any women seeking abortion to be confidential except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to women and her partner. This is a change which has taken place. So the rules under MTP Amendment 2021 are, it defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms for registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age. The powers and functions of the medical board, OBGYN and pediatrics plus radiology where available, form for each state and mandated to be provided timely evidence-based decision. So there is restriction on the days when the if any application comes, the decision has to be there within 3 days in front of the patient, so that there is no delay in procuring of services as required. So the special category of women eligible for MTP between 20 to 24 weeks is a survivor of sexual assault, women with pregnancy in humanitarian settings, disaster and or emergency situations as declared by government, change of marital status during the ongoing pregnancy, women with physical disability as defined per the criteria of Disability Act, mentally ill women including mental retardation, minors, and the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. What are the norms for the RMP? RMP is defined in the old act as MBBS or more with any medical practitioner who has assisted in 25 cases of MTP, of which at least 5 done independently in a hospital. Medical practitioner who has completed 6 months of house surgery in OBGYN. Medical practitioner who holds a postgraduate degree or diploma in OBGYN, and medical practitioner who has experience of at least 1 year in practice of obstetrics and gynecology. One RMP is required up to 20 weeks. 2 RMPs are required up till 20 to 24 weeks of gestation, and beyond 24 weeks, it is the medical board which decides. So under the amended rules 2021, an additional category of provider has been added. For termination up to 9 weeks with medical methods, RMP with experience in the practice of OBGYN at any hospital for 3 months, or training with performance of 10 cases of MTP by medical methods under supervision of a RMP in a hospital established or maintained or a training institute approved for this purpose by the government. So 1 RMP up till 20 weeks, 2 RMP up till 20 to 24 weeks, and medical board beyond 24 weeks. The norms for the RMP whose opinion is required for termination of pregnancy at different gestational age. Till 9 weeks, experience and training requirement for RMP. Experience at any hospital for 3 months in the practice of OBGYN or has independently performed 10 cases of MTP by MMA under supervision of a RMP in a hospital established or maintained or a training institute approved for this purpose by government. A practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. 6 months of house surgery in OBGYN, and a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN. This is how they define the RMP, like who all can give opinion. Till 12 weeks, experience and training required for RMP. 1 practitioner who has assisted a RMP in performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. A practitioner who holds a postgraduate degree or diploma in OBGYN, a practitioner who has completed 6 months of house surgery in OBGYN, and a practitioner who has experience at any hospital for a period of not less than 1 year in practice of OBGYN. That is what 1 RMP opinion is up till 12 weeks of gestational age. Beyond 12 weeks till 20 weeks, a practitioner who holds a postgraduate degree. So see, this is the change now which is taking place. They are gradually increasing it. A practitioner who holds a postgraduate degree or diploma in OBGYN. And second is a practitioner who has completed 6 months of house surgery in OBGYN. And third is a practitioner who has experience at any hospital for a period of not less than 1 year in practice of OBGYN. This is again up till 12 weeks till 20 weeks. Initially, 2 RMPs were required, but now the law says 1 RMP is required. Beyond 20 weeks till 24 weeks, experience and training requirement of RMP. 1 practitioner who holds a postgraduate degree or diploma in OBGYN, a practitioner who has completed 6 months of house surgery in OBGYN, a practitioner who has experience at any hospital for a period of not less than 1 year in practice of OBGYN. So now here 2 RMP opinion is required. Beyond 24 weeks, experience and training, a practitioner who holds a postgraduate degree or diploma in OBGYN, a practitioner who has experience at any hospital for a period of not less than 1 year in practice of OBGYN. Opinion of medical board is required for the termination procedure. When advised by the medical board, is carried out with all safety precautions along with appropriate counseling and at an approved place. So what is the composition of medical board? It has 1 gynecologist, 1 pediatrician, and a radiologist or sonologist. What are the powers of medical board? To allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the women at that gestational age, and whether the fetal malformations have substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. Co-opt other specialties in the board and ask for any additional investigations if required for deciding on termination of pregnancy. The note says FOXI with ministry guidelines and WHO support as a part of RAC can operationalize and host medical board information on website. What is the function of medical board? To examine the women and her reports who would approach for medical termination of pregnancy. Provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. To ensure that the termination procedure when advised by medical board is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. FOXI has an important role to play in ensuring that there are functional medical boards in every state, as is stated with MTP Amendment 2021. So with this, I would again like to remind you that registration and pre-test, post-test and feedback all are essential for getting a certificate for attending the training, and you have to submit it in time. So in India, abortion is legal. Let us make it safe and respectful. With this, I come to the end of module 1, and I would like to continue with module 2. Just give me a minute to go back and restart module 2.
If you have any question regarding module 1, you can ask directly by unmuting yourself. As said by Madam, feedback form and registration is necessary to get a certificate from RSC.
I did not, I could not give pre-test. So what, can I get the pre-test now?
You can probably go back and recheck and do it.
Go back
But
and...
during registration, you must have filled a few questions.
Yeah. During registration, I have filled the questions. Yes.
So that questionnaire itself is the pre-test form.
Okay.
So, yeah. So that questionnaire itself is the pre-test form.
Okay.
So there is no need for having any other pre-test form.
Yeah.
Is it possible to have the modules?
The modules are
No, madam.
Yes,
It's only to be given for the training.
Yeah, it is only to be given for the training of trainers.
I believe it's the Government of India
It is the FOXI
modules.
initiative.
Are they not available on the Ministry of Health?
They should be available on the website, but the modules which we are using, we have got it from FOXI office.
Okay.
Madam, on YouTube channels, you have all the modules.
Okay.
They will be there on the website also.
And we are on live stream, so all our recordings will be there on YouTube.
Okay.
On YouTube, what are we going to search for? The module.
Look for MTP Amendment 2021.
Okay. Right.
So shall I go ahead with module 2?
Ma'am, how to go about for the medical board? How we need to apply to the medical board?
As far as I am aware, we have constituted a medical board in Bhopal. And whatever I have received the information is the client or the patient who has to undergo termination, they have to put up an application in front of the board. And the board has to be convened and the decision has to be there within 3 days, looking into all scenario, whatever is there, the result should be there within 3 days of application which is received. And the first application has to go to CMHO of that particular district.
Okay.
So in Bhopal, if the application goes to JP Hospital, the CMHO office, we have a board in Bhopal and that board will be convened and the result will be there.
Okay. Is the board formed in all the districts already or it is in the process?
Madam, as far as we are aware, they were in the process, but at certain places, I guess there are some issues where it has not been there updated on the module or updated on the site.
Okay.
Shall I go ahead with module 2? It is on safe abortion. What are the various updates in technology for providing respectful abortion care? So the session overview is existing guidelines, pre-abortion assessment, medical methods of abortion, and the surgical methods of abortion. We all have been here a number of times, but there are certain changes or maybe certain areas which have been addressed in this particular module. So somebody was asking about whether it is available or not. Yes, they are very much available. Even these modules are available on WHO site. The Clinical Practice Handbook for Safe Abortion, the Technical and Policy Guidelines for Health System, Medical Management of Abortion, and Safe Abortion Care and Post-Abortion Contraception. The health workers' role in providing it, it's there on the WHO website also. So how things have changed, the roadmap to WHO Safe Abortion Guidelines in 2021. Safe abortion, the technical and policy guidelines for health system was introduced in 2014. They came up with the handbook for safe abortion. In 2015, health workers' role in providing safe abortion care and post-abortion contraception. We all are aware that was an orange colored book which had an orange color cover. It was provided to many of us. I'm sure we all must be having a copy of it still. 2018, the medical methods of abortion guideline came, and in 2019, WHO guidelines on self-care intervention for health was introduced.
Screen is not changing.
So the Ministry of Health and Family Welfare national guidelines are there on safe abortion. There are the historic changes which took place in India with introduction of 2021 amendments. It is comprehensive care mandated by law. The law changed on 25th of March 2021. Please read it as 2021. And the
We are unable to see the slides. We are unable to see the slides.
but nothing has changed from my side.
Your screen is not changing. It shows only module 1.
Okay, just give me a minute.
Yeah.
So the next module is not there?
No.
Okay,
No.
just give me a minute. I'll check
Okay.
that.
Okay. Yeah.
Is it there now?
Yeah.
Okay. So I'll just take you quickly through the changes which have taken place. This is the medical termination amendment which came as a law on 25th March 2021, and the rules changed on 24th September 2021. So all guidelines have 3 key areas in management of abortion safely: the pre-abortion care, the abortion care methods, aftercare and follow-up, including post-abortion contraception and counseling. So the decision making, if the woman chooses to have an abortion, she should be allowed to choose from the available methods that are appropriate for her based on the duration of pregnancy and her medical condition. So we need to take the medical history, the physical examination, the laboratory and investigations, and discuss contraceptive options with her. So pre-abortion assessment and counseling includes the detailed history taking, general physical and pelvic examination, laboratory and other investigations, and decision-making information on abortion procedures and counseling. As per the gestational age, we all are aware what are the changes which take place on pelvic examination and abdominal examination. So I don't think I need to go into much detail of this, but after 4 weeks, the uterus size is increased. After 12 weeks, the uterus rises up to the pelvis, and after 15 to 18 weeks, it reaches in between the pubic symphysis and the umbilicus. The key considerations are: if there is any limitation to dating by uterine size on physical examination, it could be a smaller size or a larger size. It could be multiple gestations. It could be uterine malformation. It could be uterine retroversion, obesity, or molar pregnancy. If the size is smaller than what it should be, then maybe the woman is not pregnant. It could be inadequate menstrual dating, ectopic pregnancy, or abnormal intrauterine pregnancy, where the patient can have spontaneous or missed abortion. And if the uterine size is larger than the expected, it may indicate inaccurate menstrual dating, multiple gestation, uterine anomaly as fibroids, or molar pregnancy. So the routine lab tests are not a prerequisite for abortion services. Tests that may be performed as per individual risk factors on findings of physical examination are pregnancy test if pregnancy is unconfirmed, hemoglobin or hematocrit for suspected anemia, rhesus testing when Rh immunoglobulin is available for Rh negative women, HIV testing or counseling, STI screening usually performed during the pelvic examination. Other lab tests that are indicated by medical history may be renal function or liver function test. Ultrasound is not necessary unless it needs to be diagnosis of suspecting ectopic or missed abortion. So ask the thoughts about terminating the pregnancy and reasons for termination. We need to inform the patient. We all are aware a lot of counseling and documentation is the whole idea where we want to make a behavioral change. As far as this happens, maybe we will be able to deliver what we are looking at in a much better fashion. So inform that early abortion is safe, importance of a trained provider performing the procedure for safety, available methods of abortion, risk and warning signs associated with the abortion methods. Without contraception, she can get pregnant as soon as 14 days after an abortion. Resumption of her normal activities, including sexual intercourse, any other follow-up care. The documents which are required are informed written consent and decision to accept post-abortion contraceptive. Even if she is not willing for contraception, she will be provided with the abortion services, which we all need to keep in mind. So the abortion care less than 12 weeks, which are the global recommendations, giving mifepristone and misoprostol alone, and vacuum aspiration. More than 12 weeks, mifepristone plus misoprostol alone, and dilatation and evacuation. Not recommended, dilatation and shaft curettage. The Government of India recommendations are until 9 weeks only. Up till 7 weeks, can give mifepristone 200 milligram oral. Wait for 24 to 48 hours, and then misoprostol 800 microgram can be given sublingual, buccal, vaginal, or oral. From 7 to 9 weeks, which is 49 weeks to 63 days, can give mifepristone 200 milligram oral. Wait for 24 to 48 hours, and then misoprostol 800 microgram sublingual, buccal, or vaginal. So the clinical management is medical methods, MMA, methods of first trimester abortion, and surgical methods, which are MVA and EVA. So mifepristone is an antiprogestin which inhibits action of progesterone. It interferes with continuation of pregnancy. Initial oral dose of mifepristone followed by misoprostol, which is a prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contractions, and expulsion of products of conception. The advantages of tablet misoprostol are I think one slide has some pitch. We all are aware what are the advantages. It is usually easily available. It is safe to administer, and we have been using it. So what are the various protocols? Day 1 mifepristone administration. It is like 200 milligram mifepristone oral, NTD 50 microgram if the patient is Rh negative. Day 3 is mifepristone administration up to 7 weeks, 400 microgram misoprostol, 2 tablets, 200 microgram each, sublingual, buccal, vaginal, or oral. If it is 7 to 9 weeks, 800 microgram can be given. Along with that, we may have to give analgesic, antiemetic, and offer contraception. Within day 15, follow up, confirm and ensure that the completion of procedure is there, and offer contraception if it is not done already. So how exactly the things can differ if we are giving it oral, buccal, sublingual, or vaginal? Oral pills are swallowed. The note is recommended up till 7 weeks for first trimester abortion. The side effects include diarrhea, nausea, fever, and chills. Buccal pills are placed between the gums and cheek and are swallowed after 30 minutes. The side effects are more fever and chills than the vaginal route. Sublingual, the pills are placed under the tongue and swallowed after 30 minutes. The side effects are increased fever, chills, diarrhea, and vomiting compared to the vaginal route. It has fastest onset of action and highest plasma concentration level. Vaginal pills are placed in vaginal cornices, deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. The pill fragments may be visible, and vaginal route has lowest rate of side effects. This is how the buccal and sublingual pill placement can be done. So the WHO drug regime doses: induced abortion less than 12 weeks, mifepristone 200 milligram oral once, and misoprostol 800 microgram can be given buccal for vaginal or sublingual. And if misoprostol alone is given, then 800 micrograms should be given buccal, vaginal, or sublingual. Vaginal bleeding for 2 weeks is normal after medical abortion, since bleeding can last up till 45 days in rare cases. So for the provision of MMA service, it should be available at a primary care level with referral system in place for all required higher level care. Additional services may be needed to be provided to individuals seeking medical abortions, counseling, testing for sexually transmitted diseases. The support service should be there. Psychological and social services needs to be there. Other specialist health or medical services may be needed. Need to provide iron tablets for anemia, any necessary pain medication if it is required, and needs to have provision of emotional support if needed. So the follow-up care is, routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, and address any other medical concern if it is there. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of such abortion. So the follow-up care is to assess women's recovery and ask for any signs or symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaint, and look into women's fertility goals and need for contraceptive services if not provided earlier. So to summarize MMA, what to do? Day 1, physical and pelvic examination. Confirm eligibility that she is 49 days plus minus 7 days, plus minus 49 days as per LMP. Give tablet mifepristone 200 microgram orally and offer NTD 50 microgram if Rh negative patient is there. Tell the woman to return for misoprostol administration after 2 days. Contact address and phone number of the facility center where she can go in case of any emergency. Record her experience of side effects on MMA card. 3% women may expel completely with mifepristone alone, but misoprostol schedule should be completed. So second visit is day 3. What to do? Give misoprostol 400 micrograms. Sublingual, buccal, vaginal, or oral. Observe for 4 hours. Analgesic ibuprofen 400 milligram. Contraceptive options could be condom, hormonal method. We need to tell them women mean period of bleeding could be 18 to 13 days. Possible side effects are nausea, vomiting, diarrhea, headache, fever, dizziness. Report in cases of excessive bleeding, pain, and fever. Report if there is no bleeding 24 hours after misoprostol. Then we may have to consider giving additional dose of misoprostol. 75% women abort within 4 to 6 hours after misoprostol administration. Third visit, day 15, what to do? Pelvic examination to ensure the completion of abortion. Contraception options like hormonal can be oral, condoms, IUCD, or sterilization, which is advised after 1 menstrual cycle. Tell the women about immediate return to fertility. Report back if there are no periods within 6 weeks of completion of the abortion procedure. USG is required only if it does not confirm the completion of the procedure. So the side effects and complications, pain. We need to provide respectful non-judgmental communication, verbal support, adequate counseling, need to work as a support person. Ibuprofen can be given 400 milligrams. If the pain is persistent with failure to respond to these drugs for several hours, it needs evaluation for other causes like ectopic pregnancy, infection, or incomplete abortion. The nausea and vomiting are self-limiting and reassure the patient. Diarrhea is also self-limiting, can reassure the patient. An infection confirmed by physical examination and start antibiotics. What happens if there is failure of MMA? We can offer vacuum aspiration or can repeat MMA. If there are incomplete results of MMA, then observe unless heavy bleeding takes place. In that case, if the bleeding is resolved and uterus is normal size, we consider the abortion to be complete. If still incomplete, we can repeat misoprostol or can offer any other surgical method of evacuation if heavy bleeding continues. If the patient presents with excessive bleeding PV, which is more than her menstrual cycle, what to do about it? If suppose she is soaking 2 pads in 1 hour for 2 consecutive hours, then the bleeding may decrease over time. If it decreases, then we should keep a watch on her vitals and she can go home. If bleeding increases and is not responding, then watch vitals again, do PV examination. If there are products of conception in cervical canal, can go ahead with digital evacuation. If the woman is stable and bleeding reduces, then we can observe her with vital signs and bleeding PV for 1 more hour. If bleeding continues, then USG is indicated to see whether there are minimal decidual bits, then you can wait and watch. If products of conception and decidual bits are there, then women is stable, can give her misoprostol 600 microgram oral or 400 micrograms sublingual. If the woman is not stable, then definitely need to have vacuum aspiration. And if there is continuation of pregnancy, in that case also, we need to terminate the pregnancy by vacuum aspiration. This is one of the significant things which we need to keep in mind is recording and reporting. Since MMA also comes under the preview of MTP Act, the documentation is similar to that is required for any other procedure. It is mandatory to fill following forms. Form C, which is the consent form. Form I, which is the RMP opinion. Form 2, which is the monthly reporting form to be sent to the district authorities. And Form 3 is admission register for case records. Nowadays, we are asked to submit the monthly reporting form by day 25th or 26th. So what are the various other methods of first trimester abortion or surgical methods, MVA and EVA? I'll quickly take you through this because you all have been doing it for years together, I'm sure. Vacuum aspiration is recommended for pregnancies up to 12 weeks. It is said to be the safest method and procedure should not be routinely completed by sharp curettage. The vacuum aspiration is handheld aspirator. Aspirator is attached to a cannula which is 4 to 12 millimeter in diameter. It can be used in multiple settings, including those without electricity. And IPAS or easy grip cannula size corresponds to the week of gestation, like 8 mm cannula for 8 weeks, 10 mm cannula for 10 weeks. EVA is electric vacuum aspiration, in which electric pump is used to generate vacuum. It can accommodate cannula of MVA also, which we all have been doing now. It has significantly reduced the chances of trauma to the genital organs. Cervical priming can be considered for women with pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. The recommended methods of cervical preparation before surgical abortion in first trimester are oral mifepristone or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered vaginally 3 hours prior to the procedure, or laminaria placed intracervically 6 to 24 hours prior to the procedure. It's been years together, I have not been able to see laminaria being used With advent of all these drugs, the cervical priming has changed to a lot of extent. Pain management plan, important component of quality abortion care. It reduces pain and anxiety and makes women comfortable. Two components of pain management are there, non-pharmacological and pharmacological. Non-pharmacological is providing psychological support, explaining each step to the women in advance, performing the procedure gently and smoothly, encouraging the women to relax and breathe deeply. There are various ways in which pain can be taken care of by anxiolytics, by general anesthesia, for cervical dilatation by using lignocaine, analgesics. For uterine cramps, ibuprofen can be used. If the house wants, maybe I can send this screenshot to you on the group to make it easy for you to remember, or keep it in your area where you practice doing procedures. Steps of MVA, we all are aware. We have to prepare the instrument. We have to give pain control. We have to do cervical antiseptic preparation, administer paracervical block, dilate the cervix, insert cannula, withdraw cannula 1 to 2 centimeter away from fundus inside the uterine cavity, rotate the cannula at 10 to 2 o'clock position with smooth, gentle position. I would like to mention here, they have specifically said smooth, gentle position. And if you do it this way, you provide less trauma to the organ. And I was told by my guru that if you respect the tissue respects you. And in that case, I really see this happening, that if we do gentle manipulations, the patient has less pain, we need less of pain analgesics, and even the procedure is less traumatic to patient. Release the vacuum button on the aspirator. We all have been taught n number of times what are the signs of uterus is empty, red or pink foam without the tissue passing through the cannula, gritty sensation, cervix gripping over the cannula, uterus contracting around the cannula, and can have increased uterine clamping. Inspect tissue, can do concurrent procedure if need be, like sterilization or IUCD insertion. Post procedure, the instruments to be soaked in fluorine solution, 0.5%, which assists in disinfection and help remove all other human or body fluids which are there in that particular equipment which is being used. Post procedure care for the patient, monitor her for any complications. She may leave the facility when she is stable or meets the criteria for discharge. Ensure that the woman has all necessary information and medication prior to leaving the facility, and document all the outcomes of the treatment, including any adverse event, in the facility register and client record card, which is very important. Aftercare management of abortion complications like incomplete abortion, infection, bleeding, or ongoing pregnancy, provision of contraceptive information and offer contraception counseling, assessment of any other sexual or reproductive health needs that may require additional care. No follow-up, no routine follow-up is needed unless meso-alone regime is used. In summary, India has made historic progress in improving access to safe abortion. And I think our generation is a witness to seeing these changes. We have been looking into use of laminaria tent. When we were doing our post-graduation, patient used to come with laminaria tent in the cervix. And things have changed so drastically, and we have made really historic progress as far as the facilities of providing abortion is concerned. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraceptive and counseling is essential. And that is why we all are here today, to see what other things which we can help or provide our client when she comes to us for seeking abortion services. Again, I would like to say that post-test and feedback is essential for getting certificate. I'd like to stop here, and I would like to invite our next speaker, Dr. Mudita, will you please take it from here so that I can stop sharing and she can be.
Okay, ma'am. I would like to invite Dr. Prem Priya ji for our third module.
Good evening, ma'am. Good evening, all.
Dr. Priya, you can give your short CV directly and we will then continue.
Yeah, ma'am. I'm Dr. Prema Priya from Salem Obstetric Gynecological Society. So, I'm working as associate in Vinayagar Mission Medical College. So, let's go for the respectful abortion care third module.
Thank you, Dr. Priya, for being on this platform today with Bhopal Society.
Thank you so much, ma'am. Thank you for the opportunity. I'll just share my slides, ma'am. Is the slides visible, ma'am?
Yes, they are.
So today we are going to deal about WHO's SAVER kit, that is Safe Abortion Values, Evidence, Rights or Respect. So this module aims to define respectful abortion care, highlight how norms and stigma affect services, provide WHO SAVER resources for respectful abortion care. So as Anjali ma'am mentioned, the momentum has been created, the laws are changed, and the dissemination needs association and obscene provider support. FOXY, the largest provider base for abortion care. Online training is possible due to COVID, and respectful abortion care can reach all providers. Medical methods of abortion uptake increased early and safe. However, we should ensure that PCPNT Act confliction should not be there. Patient safety, respect and quality matters more than ever, and we all have a role to play. So, what is respectful abortion care? It is adopted from the respectful maternity care recommended by the WHO, that is respectful abortion care, refers to the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. In simpler terms, respectful care means you as a provider and or as a patient treat and are being treated with dignity, empathy and compassion regardless of your race, ethnicity, gender, socioeconomic status or reproductive history, including previous pregnancies, miscarriages or abortions. If you ever feel that something isn't right, then speak up. As healthcare professional, it is our duty to listen and support. Always remember that communication is the key. So what are the norms and stigma? So coming to the stigma, the categories of disrespect and abuse includes, it could be a physical abuse such as slapping, pinching or intimidating physically. It could be a verbal abuse, that is non-consented care, shouting, screaming, scolding the patients. All this comes under abuse. It could be sexual abuse.
Hi, not audible.
Dr. Priya, you are not audible. Dr. Priya?
We cannot listen. We cannot hear you.
Dr. Priya?
Ma'am, can you hear? Is it audible,
Yes,
ma'am?
yes, you are audible
So-
now, but yeah, couple of.
Okay,
Yeah.
sorry, ma'am.
Yes. Yes, now just from there you can start probably. Yes.
Yeah,
Mr.
ma'am.
Shiva. Yeah.
Yeah, thank you, ma'am. So coming to the stigma and norms, so what are the categories of disrespect and abuse? It could be a physical abuse such as slapping, pinching, intimidating physically, verbal abuse such as non-consented care, shouting, screaming, scolding. Then it could be a sexual abuse such as abuse of power or taking advantage. Then saver videos, which you can see in the coming slides. Then failure to meet professional standards of care, poor rapport between women and providers, health system conditions and constraints. This could be the categories of disrespect and abuse. So what are the rights of every woman? Every woman has a right of freedom from harm and ill treatment, right to information, protection under laws such as MTP, POXCO, informed consent and refusal, respect for her choices and preferences, dignity and quality of care, right to timely health care and to the highest attainable level of health, right to liberty, autonomy, self-determination, and freedom from coercion. So what are the domains of respectful abortion care? There are 12 domains. It includes being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, which is soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and community security, and continuity of contraception and counseling. Coming to it is time to strengthen the implementation. As Madam mentioned, the law has been changed and it is important changes for provider opinion. Every patient is an opportunity for respect, and as providers owners, is on us to educate and also reduce sex selective abortion. So one RMP opinion is needed for MTP up to 20 weeks of gestation, and 2 RMP opinion needed from 20 to 24 weeks, and beyond 24 weeks, it should be recommended by the medical board. One provider has more responsibility like counseling, contraception, referral, and compassionate care. And there is expanded eligibility, especially the young people, survivors, unmarried. Everyone needs unbiased care, and we need to overcome our own biases. Up to 20 weeks of gestation, all women can be provided, and up to 20 to 24 weeks, it has been expanded to special categories such as rape, less than 8 years, birth defects, no gestation limit, and medical board is needed. So it is priorities to confidentiality and safety. Respect begets respect. As providers, we need to be mindful of socio-cultural aspects. So, as Anjali Madam mentioned in the previous slides in the module 1, the name and other particulars of any woman seeking abortion should be confidential, except to be a person authorized in any law. And on the grounds of failure of contraception, the contraception has been extended to women and their partner. Respect, quality, and dignity is needed in all types of abortion. And this is a saver kit, which I'll show you the video. And these are some of the links where you can play games. It is self-paced games regarding safe abortion values, evidence, and rights of respectful abortion care. So from 1970s, from the unsafe abortion, we have traveled along to safe abortion 2000s, and now we are marching towards respectful abortion care from the 2020s. So there are some recap questions. So according to WHO, restricting access reduces the number of unsafe abortions. Can somebody unmute and answer? So true or false?
Everybody can unmute and give us the answer.
Yes. So your answers are the success of this program, and we hope you all be the master trainers in providing respectful abortion care.
True.
So the answer is false. So as Madam mentioned, so for the providing abortion safe, it should be by appropriate methods and by trained persons. We should not restrict the access. So the MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before they can undergo a termination of pregnancy. Is it true or false? Do we always require a written consent from parents and guardians in minors, especially less than 18 years?
True.
True.
True. True.
So I'm so sorry. So again, the answer is false. So POXO reporting is still needed, but abortion services should not be denied. We need to provide bias-free services without judgment.
Excuse me, you mean to say that if there is a girl less than 18, we do not require her parent and guardian's consent before we do an abortion?
Ma'am, we should inform, but written consent is not mandatory.
Then whose consent are we to take? Whose consent is required then? If the girl is less than 18, whose consent do we take?
Is that Dr. Geeta?
Yes.
Is that Dr. Geeta? Yes, this even when we had this master training program, we were having a lot of arguments on this question.
But I would like my question to be answered. If the girl is less than 18 years, whose consent do we take if not the parents and guardians? If the girl's consent, can we do an MTP on a girl's self-consent if she is less than 18?
Madam, actually, there are a lot of loops in this.
No, we want a yes or no answer. You are saying true and false. We want a yes and no answer. Because after all, we will be in the private sector and we will be doing an abortion. If you say that we don't require the parent or the guardian's consent, can we quote you?
Madam, this is said that...
Can we quote you?
Yes, anyone, whoever accompanies her need not be a parent or a guardian.
It could be her boyfriend?
Yes, that is what we were told.
Has he to be over 18?
Yes, that is required. That is required. That is true.
Is this written anywhere? Have we got documentary evidence of this?
Madam, this has been given in the module as well as it is there on the website that parents and guardians are not required. Anyone who is accompanying her, if the person is above age of 18, can give consent.
I think we need to see the Gazette again, Anjali.
Okay.
We are misrepresenting the Gazette.
Madam, we had a lot of argument when we were given this for training thing. And this is what we were told, that parent and guardian, they are mentioning specially. So anyone, even the boyfriend, the brother, the sister, anyone can sign it. If they are above 18 years of age, need not be parent or guardian.
Ma'am, but POXO reporting is required. We need to send the POXO reporting for this.
Yes, that is required. That you can't deny that. But as
we can't deny the
POXO
abortion
reporting as well as informing the police,
Yes, ma'am. Informing police is required.
Yes, that is required. And anyone, whoever is whether you provide services or not, you will have to report to the police. Hello. Yeah, Dr. Madhuri, definitely I'll try to get a proper documentation and provide you. But even we had a lot of discussion on the platform, and the question says parent or guardian, and that is why the answer is false.
But even the brother and sister will become guardian.
Yeah, they can, but they may not be legal guardians. They will be guardians, but the boyfriend will not be a guardian. So the answer is like, I think this is where the answering of multiple choice question comes into picture. Like, what is the best? And since it is parents and guardians, the answer will be.
But I don't think any friend can give consent for the procedure.
Yes, they will not be. It will not be legal. It will not be legal consent.
Happens, who will be responsible?
Madam, will just portray your concerns to the head office and will get back to you.
Ma'am, you can mail to foxy@rac@gmail.com.
Yes, I'll provide.
Especially
we'll provide the
since you are
email.
addressing the private sector also. If
Yes.
it was in the government sector, I would ask the superintendent of the hospital to give consent. That is allowed. But in the private sector, I don't think there is any superintendent of the hospital to give consent.
No,
So we
very
need
true.
to be very
Even in government sector, superintendent of the hospital cannot give consent. In
They
at the
can.
place of parent, how can superintendent give consent?
There are many times that girls come and there is no attendant with them, or it's an emergency situation. At that time, the consultant in charge and the superintendent of the hospital signs.
The emergency situation is like it will be the bleeding then. If it is bleeding, it is no more an MTP. It is then incomplete abortion then.
Yes, agreed. Madam, we will put it on the RAC email ID which we have. I'll give you that ID also. And this was a question which we also had a lot of arguments when we were having the training. But the answer which we were given was this one only, that since it is asking for guardian and parents, you can't deny services to them.
I think we can have a show of hands. How many of the people in private sector will do an MTP with no consent of parents and guardian if the girl is less than 18 years?
Even I'll not do it. Even I'll not do it.
I will not.
I'm not doing.
Definitely.
At least one of the parents should sign.
Definitely.
Yes.
We will echo this to the head office, madam.
Yeah.
Sure.
Because lastly in the court, finally in the court, the gazette, whatever MTP law says, that will be considered.
Yes.
Shall we move to the next one, ma'am?
Yes, please.
So a 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy.
No.
Decision is hers.
Yeah. So I think this question has no debate. So no. Yeah.
No.
Yes, ma'am. Thank you all. So in India, abortion is legal, and let's all work towards making it safe and respectful. So I'll share a video regarding the Saver Kit. Is my screen visible, ma'am?
Yes, it is.
Yes.
Visible.
Okay. No. What is this?
Can't understand what is going on.
Just can't understand. It's going on so fast. Can't read even.
I think the video is not completely working.
It was all text.
Ma'am, this is basically the Saver Kit which has been provided by the WHO.
For what? We could not read anything.
We'll share the WHO kit with you, madam. Dr. Priya, can we? Yeah.
Yeah, yes, ma'am.
And there was no audio with the kit.
Mm.
Can you explain the video?
Ma'am, you cannot.
No,
It's not
no.
audible, ma'am.
No, it's not audible.
Okay.
The volume is not
Ma'am,
there.
we should quality, safety, dignity should be done, ma'am. And it has 4 modules. So it's for doctors, nurses, health providers. To address our biases and learn together towards the goal of respectful abortion care. So during COVID pandemic, we adopted WHO Saver Kit. It could be done either in person, online, or in combination. So it has 4 modules. First is engage, inform, explore, and equip. So the participants look towards the gender, unintended pregnancies around globally. In the inform module, they discuss regarding the SRH modules. Regarding the participants will go through the abortion law, safety globally. In the explore module, the participants will play games regarding the gender, unintended pregnancies, and how the stigmatizing attitudes from the personal perspective. So in the equip module, they use the contraceptive methods and modules, ma'am. So actually I mentioned in the previous slide, the WHO gamer helplines, especially the HTTP links, ma'am. I'll share it with you so that you can go and play the games, especially regarding the WHO Saver Kit.
Okay.
So I'll share the link.
Yes, please do that so that maybe
Yeah, ma'am.
Yeah, we
I'll
can
share.
show it to them.
Yeah, ma'am. By the end of the within the next one module can be started, ma'am. I'll share in the middle, ma'am.
Yes. Okay. Sure. Dr.
Thank
Mudita,
you.
would you? Yeah. Dr. Mudita?
Just 2 minutes, I'll start sharing my
Yes.
slide.
Yes.
Till then, can I ask one of my doubts?
Yes, ma'am, please.
Yeah, are we supposed to prescribe the medical abortion pills or always to provide from our side?
Ma'am, as per the module, it has to be provided on site. That is what the module says.
So are we not supposed to prescribe then? Because the law which we previously read, you have to give in two copies. One copy will be saved by the chemist and one copy will be with the patient and one copy you should have. All those things we read in the past.
Ma'am, this time there is no clarification regarding this.
Okay. And one more question is, what is actually the difference between safe abortion and respectful abortion?
Ma'am, they are just going beyond calling it as safe abortion, like respectful maternity care. They want to portray this as respectful abortion care. Pretty much the thing are same, like confidentiality and everything else is there, but they have a hand of empathy, like what is there with respectful maternity care. They want to have that with abortion care also.
Yeah.
Yes, Dr. Mudita. One question was there which was already answered, like if we have to report to the police, yes, we have to report to the police if the patient is minor. Then second question, which was there, whether written consent is required. Yes, the patient, we should have a written consent. All formalities are to be kept with us the way we have been keeping it confidential, kept in envelope, has not to be disclosed. Those all norms are there still with this act also.
One more thing I wanted to ask is when we are sending the monthly reports, the pro forma which we are provided from the CMO office, in that there is a column of name and husband's name. Then if we in the monthly report, if we are writing the name, where is the confidentiality then?
Madam, it was told to me by our CMHO office at Bhopal that we don't disclose it to anyone else. It goes only to the person who is in charge. We also ask them, because I'm on the board right now, and I did ask them, one way you are talking about the confidentiality, and other way you are asking us to report online in the format. So how are you keeping the confidentiality?
Yeah.
No, the slide is not visible. So I was told that it from your part, it goes to part A to Z, and we don't disclose it anywhere else. That is what I was told.
But that is really doubtful.
I agree with you, madam. I entirely agree with you.
Yeah. And how can I become a part of trainers? Because this
madam, it was opened from Foxy head office, and your society was supposed to send the names. Unfortunately, there was a very short notice period. That's why even from my society, I could not send many names. But in the end, somehow me and we were able to talk to them and put our names. So that is where, like you all are aware, we have DHERA program going on. So they ask for respectful abortion care trainers also. But if you want to have maybe the email ID is there, maybe I can share the ID with you, and you can write to them. If but I'm not sure, they don't have any master training programs now. The one which we also took was one of the last ones.
Okay. Madam, I am not able to share my slides.
Okay, shall I go ahead and show it?
Yes, ma'am.
Just give me a minute. Till that time, maybe if you can start with it.
Okay, ma'am, I'll start. So model 3B is regarding pre and post abortion family planning counseling. We are leveraging technology for referrals and online consultations. So as we know, respective
cannot be seen.
As we know, respective abortion care is the joint effort of Foxy and WHO initiative.
Vandita, your not screen not visible.
Madam, she doesn't have the slides. Just give me a minute. I'll start showing you the slides.
Okay, also there.
Vandita, you can put yourself on. You keep your video on, and let me just work it out, because I have not downloaded this particular one. I'll just go ahead, download, and start showing it. Dr. Vandita?
Yes, ma'am, I'm starting.
Yeah.
Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feeling, and perception. So, as we know, counseling is an integral part of comprehensive abortion services. It is as important as the procedure. Women may need help in decision making. Wherever needed, the spouse should also be counseled for the same. So, pre-procedure counseling critical role. So, what we need to do? We need to help women decide about termination of pregnancy. We should help the women to choose the method of termination of pregnancy. We need to ensure delivery of complete information about the procedure. We need to help women to adopt the contraceptive method. So what this pre-procedure counseling means? How do we need to continue the pre-procedure counseling? We should always ensure the privacy and confidentiality. We have to be non-judgmental and be sensitive. We need to establish the rapport with the patient. We need to use simple language and allow the women to clarify her doubts. If she has made up her mind for termination of her pregnancy, we need to assess her for the procedure. So, what is the relevance of peri-abortion family planning counseling? The peri-abortion family planning counseling results in quick return of fertility, opportune time for contraceptive acceptance, minimum 6 months gap before next pregnancy, health benefits, and better future pregnancy outcomes. 90% of abortion-related mortality can be prevented by ensuring contraception. So, pre-abortion family planning counseling. When to start? We need to start it during her first visit or her first consultation, with the exception of grief management delay. And what we need to counsel? We need to counsel them the importance that their fertility can return within 10 days to 14 days. We need to help with choices. We need to help with specific counseling, high-risk behavior wherever applicable. Dr. Shivani, Father, can you please mute yourself? Thank you. So, counseling regarding fertility, help with the choices, method-specific counseling, high-risk behavior wherever applicable. If the woman is not willing for any contraceptive method, we cannot refuse MTPs. We can try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week's time and counsel her. So counseling is the main part. Assessing.
Can you see my slides, Madhika?
Yes, madam.
Okay, so just give me a minute. I'll start with it. Okay. Yeah. So have you been through this?
Yes, madam. I am on slide number 7.
So just let me know which slide is that, because I can't see the number now.
Yes, ma'am. Next slide. Yes, ma'am.
Yeah.
Thank you. Yes, ma'am. I will continue from here.
Yeah, sure.
Oh, thank you. So assessing suitability for post-abortion contraception, that is general guiding rules. Abortion process is complete, no existing infection, no injury to genital organs, chances of fresh pregnancy rule out. Post-procedure counseling critical. It definitely has critical. We ensure women has understood precautions and care needed during post-abortion period. Opportunity to counsel for contraception in case not previously accepted. Reinforces the need for continuing the use of contraceptive method chosen. Post-procedure counseling. So we need to continue to ensure privacy and confidentiality. We need to reassure her in case of any problem. We need to repeat the information about post-procedure care and danger signs. So, post-abortion family planning counseling. Madam, please change the slide. Already opted. So we should appreciate. We need to tell her about immediate care of IUCD or MPA. We need to tell about ongoing oral pills. We need to tell her follow-up protocols, continuity of reproductive institutions or cards. If undecided, then we need to allay her anxiety, importance of immediate adoption and choosers, extended period of adoption, couple counseling, and emergency contraceptive pills. So what are the post-abortion contraceptive methods? So first we have barrier method. We can provide what are the timings after abortion. After first trimester abortion, as soon as sexual activity is resumed, they can use condoms. In second trimester, also the same. However, there is no side effects. It can be used without consulting a health provider. It is easily available. It prevents against STDs, HIV, and enables men to take responsibility of contraception. So, the second method is IUCD devices. So, IUCD 380A, IUCD 375. After first trimester, we can insert immediately or up to 12 days after confirmation of completed abortion using the surgical method. With manual with MMA insertion around 15 days of process, provided complete POC exposure is confirmed and risk of presence of infection or any other contraindication is ruled out. After second trimester, it can be inserted immediately or up to 12 days after procedure is complete and contraindications are ruled out. So it is highly effective. It provides long-term contraception for around 5 days for IUCD 375 or 10 years 380A. It can be provided by doctors, that is MBBS and above. A&M nurses after first trimester surgical abortions, by trained doctors only after MMA, and by PPIUCD trained doctors after second trimester abortions. No interference with sex, immediate return to fertility on removal, and no hormonal side effects are associated with IUCDs. The third is hormonal contraception, that is oral combined contraceptive pills. So after first trimester, immediately or up to 7 days after abortion using surgical method. With MMA, it can be done on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of completed abortion. After second trimester, it can be done immediately or up to 7 days after abortion. So along with the contraceptive effect, you all know that it can regulate menstrual cycles. It can be provided by all health workers after first screening by trained providers. No interference with sexual activities. It offers protection against ectopic pregnancies, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenopathy. However, it is not suitable for women who are breastfeeding babies less than 6 months old, so for them we do only progesterone pills. Next, long-term injectables, that is medroxyprogesterone acetate. After first trimester, it can be given immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol. After the second trimester, it can be given immediately or up to 7 days after abortion. The permanent methods are definitely with female sterilization and vasectomy. It can be performed after an abortion in absence of any infection or severe blood loss. Concurrently or up to 7 days, both mini-lap and laparoscopic can be done. With MMA, it can be done only after the first menstrual cycle. Second trimester, mini-lap sterilization. Mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended. Vasectomy is very effective permanent method of contraception. It can be performed of male independent of timing and procedure of the abortion. Next slide, please.
Just give me a minute. It has refused to move. Just wait. Yeah, go ahead, please.
So these are the contraceptive measures. It's available. Chart is available. You can have and try it. Next slide. These are the contraceptive methods with active aspirations. So combined pills injections can be done. So SRS services, teleconsultations, and other technologies. So what are the leveraging technology service provision? We can have teleconsultations, we can have telecounseling, we can have teleguidance, we can have telereference, we can have telelinkage. So what is Techno-IE? It's website Humdo. You can check Humdo websites, social media, Ask Tanu or YouTube. We have infographics, we have helpline numbers. The helpline is given in the pics provided below. And patient education platforms are also available, WHO, MOH, FW, and RCOG. So what is the SWOT of teleconsultation? What are its strengths, weakness, opportunity, and threat? Strength, that is definitely in COVID era, teleconsultation was definitely very helpful. It is approachable throughout the process and it gives us the confidence, awareness, spread out questions and answered it is. Weakness, face-to-face consultation is not possible and demonstration is not possible. Opportunity, it provides you privacy and comfort, it's cost saving and number of visits are cut down. However, what is the trend is misdiagnosis and missed opportunities. So applicability of components of CSEs. So assessment, confirmed diagnosis, contraceptive need, counseling done by video conference or Zoom follow. So hybrid services are available, 1 visit and MMA 3 visits had to be done. So the key message is realize the need of PIP, bring the couple on board and strive for 100% coverage, capitalize on the basket and applicability in period, post-abortion period, technology as far as possible, serve for anti-CHE services, concern policy, malpractice, service costs and assets. Adolescent RH needs both online and offline. So for this, please do registration, pre-test, post-test and do submit feedback. Whenever the session will end, there will be a feedback form on this page only. You need to have the feedback form. Certificate will be awarded to the participants on attending the training and submission of registration of pre, post and feedbacks. Do send feedbacks. There are few questions, Anjali ma'am.
Yeah. So again, in India, abortion is legal. Let us make it safe and respectful. The thing is, for the post-test part, don't leave the meeting as such. There will be a pop-up which will say, we'll like to continue and continue with the post-test. You need to continue on that. And after giving your post-test only, you will be getting a certificate. So the question which I could read is from Madhuriji. It says, can't find any reference to parents and guardian consent not required in amendment 2021 of MTP rules. We will definitely convey this to the head office and I'll let you know what answer we get on this. Even when we had our master training session, we had a lot of people talking on this, and the answer which we got is definitely anyone who accompanies the patient, he or she can give the consent, need not be a parent or a legal guardian. I definitely understand in private setup the things are way different and they have to be extra careful as far as the consent part is to be taken into account. Any other question if anyone else have? So
Dr. Priya has said, share the WHO play game.
So can you send it on the group maybe, Mudita?
Okay, madam.
So we can do that.
Is there a WhatsApp group or some group?
No, madam.
Which group you are sending? Which group you are talking about?
Either you can get it on MPOX group where I did send
Okay, MPOX group.
Pardon?
It's in the chat box also.
The link
Shall
is
we
there.
leave the meeting? Thank you so much.
Yeah.
Madam, this is Sriman.
Yeah, please go ahead. Yeah.
I'm posting a post-session feedback link in the chat box, madam. If you click on that link, you'll directly redirect to post-session feedback. You can fill and you can submit, madam.
Okay. Can you just repeat it once more?
I posted the post-session feedback link in the chat box, madam. If you click on the link, you'll redirect to the post-session feedback page. You can fill and you can submit, madam.
So again, the request to all the members that the link is there on the chat box for the post-test and feedback form. You click the link. I'm able to see the link on my chat box. If you can click that link will take you to the post-test and feedback form, which is must for getting the certification. So please go ahead and fill those questions.
For that, we have to first leave the meeting.
You don't have to leave. It's there in the chat box. You just have to click that. Please click.
Okay.
It's there in the chat box. Go to the chat box. The link is there. Any issue with that?
After clicking the link also, you can leave the meeting, madam. You can fill the process.
Anjali, let me interrupt again. I can't find any reference to this parents and guardian consent not required in the amendment to 2021 of MTP rules. And I've also rung up Dr. Archana Mishra to ask her, and she also has no knowledge of this particular statement. Okay. Are you all very, very sure that we are not to take consent from a girl less than 18?
Didi, probably I'll send you the link.
Or is this a mistake?
No, we'll check with the head.
That was Dr. Priya giving the lecture. So let me address this question to her.
I'm not sure whether Priya is there or not as yet, but I think we will refer it to the people who were there on the RSC training module. That
I think so. They should have read the whole Gazette at least 3-4 times before they made this statement.
Yes,
because I can't find any reference like this.
Didi, even we had a lot of arguments when we were
Did you
there.
find the reference? Did you find it? So I'll look up that page again.
No, I didn't find any reference to such. Even we were told that the question is framed like this. That is why the answer has to be no. We all failed this particular question n number of times, as many times as we had to fill the post-test form. But definitely we'll let them know that this is the query, and whatever answer we get from them.
Are these modules from Foxy?
Yes, these modules are very much.
I will ask the Foxy MTP committee in charge this particular question.
Definitely, Didi. It will be great on your part.
Sure. I'll get back to you all after I address this question to her.
Yes, Didi, definitely. Sure. I hope all of you are able to go join the link and get to the post-test form and the feedback form. Hope there is no issue on that. If you all have done it, then we would like to leave the meeting. Nani?
Madhuri madam. Ma'am, is she there?
Dr. Mudita, do you have any idea regarding that question which Madhuri is asking? Because you are also there on the MTP.
I am a member of MTP committee also. I will also ask Dr. Richa Sharma, who is the chairperson.
Yes, please.
Because this is, widely, if we are doing this and in the end, if somebody it stucks up in the code, that will be very much
not only that, madam, our whole attempt of putting this in front of our members will be at fault.
Yeah, fallacious then. Yeah.
Yes. Thank you, ma'am. Shall we leave the meeting? Dr. Mudita? Thank you everyone for attending this particular meeting.
Thank you so much, Dr. Anjali, Dr. Mudita, Dr. Prabha. Yeah, thank you so much.
Thank you.
Except that question, everything was very nice. Everything was very nice.
Madam. Thank you so much.
उस क्वेश्चन ने थोड़ा प्रोवोक किया अपना डिस्कशन, so we'll work on it. Thank you, ma'am. Thank you everyone.
Is anybody still there?
Yes, Madhuri, I'm very much here.
Okay. I think the phrase of that thing is not correct. You require consent from parent and guardian, but not that the adolescent does not require to get written consent from both parents. She can have anybody's consent, parent or guardian, and she doesn't have to get the consent. We have to take the consent. The phrasing of that sentence is in that way that it comes out to be false. Because I'm doing the questionnaire and I've come across that question again. And let me read it out to you. In my country, law requires an adolescent. It doesn't require the adolescent to do it. It requires us to take the consent. From both parents, no. One parent would be enough, or / guardian, before she can undergo a termination. That is why the answer is false.
Okay, Dee. All right.
Okay.
Yeah. Thank you so much, Dee.
Okay.
Yeah, submitted. Can we leave now?
Yes, ma'am.